Today, we have with us Dr. Rajesh Bhayana, who is a radiologist supreme as well as the technology lead for JDMI.
We touch every part of the hospital, right? So emergency care, surgical care, oncology care, everything needs imaging. Most patients in the hospital touch the imaging department and touch imaging IT. We need the systems to be reliable.
We keep hearing about agentic AI. What are these agents and what do these agents do for us?
But at the end of the day, the AI is going to be good at certain things and we're going to be good at certain things. And we're not going to be out of a job as a result of that for sure.
Speaking about technology, so anytime we think about radiology, we always narrow in, laser in on images because that's kind of what we all deal with. We're acquiring the best images. What are the technologies available? How best to get those images and how do we interpret them? However, oftentimes we forget that there is a whole layer of technology behind it because now after acquiring the images, how do you transmit over? Where is it stored? How are you viewing it? How can you manipulate it? And how are you kind of reporting it? Because the final report is the product. So how do radiologists need to think about the technology behind it and why is it often so overlooked?
Yeah, I think there's obviously a lot going on behind the images themselves. I think as radiologists, we're used to clicking on a button and the image appears right away.
Yeah.
And if there's a 10, 15 second delay, we get frustrated.
Call IT. Hey, why is it not showing up?
Exactly. And I mean, it's okay to be frustrated. I think we should have high expectations of our IT systems.
Absolutely.
That being said, there is a lot going on. There are many systems that need to work together so that we can do what we do.
Okay.
Right. And so, there's the RIST, the Radiology Information System. There's our PACS. There's storage solutions, archiving, networking, there's the modalities themselves and the software on them, post-processing, and then what we see on a day-to-day basis. So our PACS viewer, our work list orchestration, reprioritizing studies, voice recognition software, and I think increasingly now a layer of AI applications. So tools, but also the infrastructure that powers those tools. Continues to evolve. And so even that list, it's brief, but it just scratches the surface of all of the things that need to work together and need to be stitched together and integrated together to allow us to do what we do. And I think radiology IT is one of the two most foundational pieces of software or groups of software in a hospital, right? You have your health information system or HIS, like Epic. And then you have radiology IT, and we touch every part of the hospital, right? So emergency care, surgical care, oncology care, everything needs imaging. Most patients in the hospital touch the imaging department and touch imaging IT. We need the systems to be reliable, and work well. And so that's where, strong integration comes in.
Okay.
I mentioned Epic, the HIS system.
Yeah.
And if you haven't heard the podcast yet, there's a podcast Acquired. I don't know if you're familiar. They did an episode on Epic Systems. That's an excellent episode.
On Epic, the hospital information system.
Exactly, on Epic Systems and MyChart as well. But Acquired is a podcast that covers this, deep dives into the most important companies in the world, including Epic Systems, and they do some other health-related ones. But it's a high recommendation to listen to it. It's an interesting story. If you're interested in healthcare, or I'm sure most of the listeners will get a lot out of it to understand the systems and the story behind what brought Epic to become, such a dominant player in that space.
Okay, so what was the key takeaway from that?
Yeah, so it's a 4-hour podcast, so it's hard to necessarily take one thing out. But if I were to take, I think probably the most important thing to your point is that they made a conscious decision to have a unified or a single unified database that powers everything. So all the applications are pulling from a single unified database that allows unified workflows. It facilitates things like care everywhere, where data can flow seamlessly from other hospitals that have Epic, for instance.
Okay.
And that unification brings simplicity, on an administrative level, but also reliability. Okay. And so, Epic didn't win because of user experience. I think we've all used it. It's not bad, but it's
Yeah, we still get frustrated with Epic as with any other hospital system. I guess.
Exactly. I don't think many physicians are, praising the UX or, user interface as the reason why it's the best. But it's the reliability, the unification that kind of had it win out. And I think we can learn a lot from that in radiology IT to have unification where possible, but
Yeah, so
also,
the way you say it is that radiology IT is a bunch of individual components. So you have a software running on the scanners themselves. Then there is archiving, networking. That interfaces with the RIS platform and it comes up. But the PACS platform is separate from the RIS. But the reports are dictated in a voice recognition platform, which is separate. And then all of these have to somehow be bundled back into the hospital information system, which can then go to the clinician. So there are lots of individual components as opposed to Epic, in which there is a single unified one. And I think at the end of the day, the weakest link, we are only as good as the weakest link, right? So where do you currently think that the systems are either weak or outdated, or they need better communication or better unification?
I mean, it changes all the time. Like you said, if any piece of that puzzle with all of those integration breaks, we can't deliver the care that we deliver. And so we've all experienced it, right? If the networking goes down, obviously we can't do anything.
Yeah.
If other pieces of the puzzle go down, our voice recognition software, any piece of the cloud, any piece of that puzzle is broken, we can't do our jobs.
Yeah, even like other outages, right? Windows outage we had with that
sure.
Cloudflare and all that stuff.
There's so many pieces to the puzzle. And I mean, it's going to be that way. There's not necessarily an easy way to unify all of this. There has to be specialization and especially for add-on applications, you want to have specialization and deep integration is good between these companies. But where possible, you unify, I think. And the lesson is you also want to make sure that if there are integrations, they're strong, tried, tested, and true integrations. It's harder to integrate something for the first time out of box. We saw that when we integrated Epic and Cora, let's say, which is our in-house risk packs. That brings challenges.
Absolutely.
I think our team did a great job, but it's obviously more challenging than integrating solutions that have been integrated time and time again. So we're as weak as our weakest link, but we're also as weak as our weakest integration. And so I think thinking about things in a way that helps us unify or at least integrate strongly, at least for our core foundational systems, is important. There's always going to be little add-ons because people do subspecialized work in very narrow areas and they need applications for that. So there's going to be heterogeneity, but we need to try our best, at least for the foundational systems, to try to unify and integrate.
So yeah, you're right. The weakest link and the weakest integrations are the worst for us. So currently, what do you think are our weakest links? Where do you think the processes are currently very manual or very outdated that in 2026 we shouldn't be doing this? In your opinion, what's the weakest link now?
Yeah, I think there are a lot of manual processes, things that are manual that probably shouldn't be manual and as a result are suboptimal. So, where do I start? But I think, to choose a few concrete examples, anytime any physician orders imaging, they have to manually click 10, 15 times. They have to write a clinical history from scratch about the patient as to why they're imaging the patient.
Absolutely.
They're doing this again and again and again. So we know, as radiologists especially, and every radiologist or anyone adjacent knows, that those histories are suboptimal. Right?
Yeah, and it's not a recent problem. Like I've seen literature from over 100 years ago saying that, radiology histories are suboptimal. And x-rays were invented barely 100 years ago.
100%. It's an age-old issue in radiology that we have suboptimal histories, and it impacts how we do the imaging. It impacts how we read the imaging, right? We're more sensitive if we know what the tumor is. I think in over 10% of patients, we don't even know what the primary tumor is in oncology
imaging,
which is, obviously very suboptimal. So that's, a current manual process. People don't have time. They're busy. There are detailed clinical notes in the chart, but they have to manually type this out again and again, and that leads to suboptimal manual processes.
Absolutely. For audiences who aren't quite aware how radiology works is that sometimes we think that, you look at images, who cares what the primary is? But it absolutely matters. Because if you see something very, very tiny in the liver, in a patient with colon cancers have a high chance of metastasizing to the liver. So then it's likely metastasis. Whereas if you see the same in an ovarian cancers virtually never go to the liver. So the chance of it being a metastasis is very, very low. It's probably something else like a cyst or something.
Exactly.
So knowing the primary is very, very crucial. In addition to the treatment the patient is on, which drug the patient is on, because a lot of side effects of the drugs can mimic it, and you can have a lot of changes due to the therapy itself.
Yeah, I mean, we talk about this all the time, but the pretest probability, right, impacts how you read the images, and the information we have when we read the study is the history.
Yeah.
And so that's one piece of it, the history, but obviously the history also helps inform the manual and painstaking process that we undertake every day when we're protocoling studies.
Oh, absolutely. Like protocol is how we do a study. Do we do it
Exactly.
only on contrast, or do we do an arterial phase? Do we do a venous phase? Which area we cover, and all those
So
instructions.
for CT abdomen and pelvis, there are more than 40 different ways that we can image the abdomen and pelvis. And for those unaware, protocoling is the process of looking at the clinical details and choosing which one of those 40 ways should we do this particular scan. And how you protocol obviously matters. If you protocol incorrectly, you may not pick up on the key abnormality. If you do you don't do an arterial phase in a hypervascular malignancy, you may miss metastases and so on and so forth. And there are many examples that we can give of that. But the point I'm trying to make is that that's a very manual, time-consuming process right now. And it, as a result, becomes suboptimal, right? There's heterogeneity in a department. People are doing this again, you're doing hundreds at a time. So you're more likely to make mistakes. So that's another kind of, I think, weak link in our workflow right now that is primed to being made more efficient and higher quality, I would say. And then the third is reporting. So it wasn't too long ago, but it's before my time and maybe yours as well, but it wasn't too long ago where radiologists would dictate with a transcriptionist. So you would just dictate once, send it somewhere, they write the report, and you're done as a radiologist. And with the advent with the invention of voice recognition technology, we now dictate, we now look at our report, and now we have to edit it, check the spelling. You're off by a field, you're toggling through fields, you have to cut and paste.
Yeah.
It's a painstaking manual process as well. And radiologists have really taken on that administrative burden.
Yeah, you got to
which
spell check, correct, format.
And it doesn't make sense, right? It's like, your time as a radiologist when there are many studies on the list and patients who need care, if you're working on the administrative aspect of that makes you much more inefficient and also suboptimal. If you only have so much time in a day and you're spending X percentage on administrative cutting and pasting in your reports, you're spending less time looking at the images likely. So that leads to suboptimal reports as well.
And when we are speaking about how to fix all of these, what would your overall approach be? And, the last 10 years, we are speaking about AI. And even in the first episode, we were talking about how AI can pass an exam. And a lot of it seems party tricks. Do you think that AI is good for any of these? Or do you think that we have to find other ways of efficiently fixing the problem?
Yeah, I mean, I think the focus of a lot of AI research for many, many, many years was largely image-based.
Yeah.
And, there's obviously advances there as well. But as we talk about some of these workflow inefficiencies and we talk about, ChatGPT itself and, party tricks and passing exams and, text-based answering of questions, that's one thing. But there are ways to optimize LLMs to use them for these problems.
Okay.
And, that's what we're doing. And so to answer your question, I mean, if you look at the radiology workflow from the time when a requisition is placed, or even the time that a physician decides they want to place a requisition, decision support, and then everything downstream of that. So writing the history, the protocoling, the reporting, downstream of the report as well, there are opportunities for the LLM, or LLMs, I should say, to be integrated in a way that improves what we're doing or makes us more efficient and better quality as well. And so, to answer your question, clinical history, we did some research in that regard. LLMs do very well if you optimize them to pull those details from the chart. So, what's the primary tumor in an oncology patient? Do they have other tumors? What medication are they on, if any? Have they had surgery? If so, what is that surgery? Do they have acute symptoms? They often don't tell us that they're sick. They just say staging, follow-up, and the patient may have an active obstruction and you don't know. But LLMs are very good at pulling these details because at the end of the day, the radiologist only needs, a handful, I should say, of pieces of information when we're reading oncologic imaging. And it's very good at pulling that information when optimized and implemented the correct way. So we've done that in the research space and we're working on bringing that clinical, but it's not yet in the clinical space.
Traditionally, before the LLMs, machine learning, if you're instituting a change, you send an email out to everybody, have a training session, tell everybody that this has changed, and you hope that the people are actually listening and they actually remember it the next time they do it. When you do it a purely machine learning approach, you're kind of stuck because now you have to retrain the entire thing with the new policies. But with large language models, all you need to do is go in and change the instruction set, just add a line saying that, hey, if this indications, don't give oral contrast, and then it's just kind of done.
Exactly. So state-of-the-art LLMs are designed to be very good at following instructions. I think most research that's out there, they kind of just give a short prompt to the LLM and move on. But if you really give it all the context it needs, like very granular and detailed offloading of your mental model as to how you protocol or do something in painstaking detail to the LLM. Our protocoling prompt was 7 pages long, for example. And it's a painstaking process to initially make it, but then it kind of behaves how you would like. Exactly that. And then to move on to the next wave, I should say, of AI integration into dictation. So things like Nuance PowerScribe 1, RadAI's platform, RadPair. There are many of these vendors in this space now, but they all kind of do a lot of the same or bring a lot of that same value. And the biggest, I think, unlock for our efficiency is, you can look at the images, dictate your findings free form. And all of that administrative burden of sorting your findings, putting the findings in the right categories, even things like auto opinions, structured reporting, that is kind of taken care of for you. So, you can keep your eyes on the images, doing the high value task of interpreting those images and leaving that administrative burden to the AI. Of course, you still have to check it. And, they do things like, unlock auto opinions that can make you more efficient. You still check that. So all of these are kind of doing that as well. Locally, we don't have any of these newer tools yet, but we are using like our own in-house built reporter. It's called AutoRads. We work with the Cancer Digital Intelligence team to bring that to pilot, at least right now. And so that enables us to do the same. So we're able to dictate free form. We're able to have it, auto structure the report, give us an auto opinion, and to take it one step further, do things like calculate cancer risk scores. So things like auto LIRADS, auto ORADS, giving us a synoptic report. To my knowledge, that's not something that these companies are doing, but that also drives an extra layer of not only efficiency, but also quality. I think these systems are underutilized. It actually impacts care. And, at the end of the day, if we're able to use AI to help increase the use or utilization of these systems and the quality at which these systems are used, it's a win for patient care. So
that's amazing because, number one, structured reporting in many places is not routinely done. And we had a visiting professor lecture just yesterday telling us the advantages of structured reporting. Secondly, many RAD systems are not used in many places. And thirdly, when they're used, they're sometimes applied incorrectly. And all of these are due to the mental extra processing which is needed. And you're saying that these LLM-based approaches can help alleviate all of that. However, I still don't understand something. ChatGPT, I understand, you give it a prompt, it can write you an essay, it can write you a poem. It's very good in creative tasks. And oftentimes you're like, okay, it can hallucinate stuff. But the stuff which you point out, like in terms of creating history, protocoling, and reporting are kind of very diverse tools, different from that. They still handle language. But how do you integrate ChatGPT into all of this? Like, how do you put a chatbot into this?
Yeah, so there's two aspects that I'll touch on. The first is using it safely and securely. So, obviously, ChatGPT, Gemini, Grok, all of these chatbot applications are just applications. And they're owned by their respective companies, like OpenAI, for instance. So anything you put in the system,
the data
is
goes
owned
to them.
by that company. They can retrain on it, etc. And definitely not HIPAA compliant by
Yeah, we don't want to put
any-
patient data on it. Yeah.
Exactly. You cannot use any of those systems for anything
Okay.
related to patient care. You shouldn't be.
Okay.
That being said, those applications are built on top of or built using large language models or LLMs, which are giant neural networks that can be accessed securely if done the right way.
Okay.
And so the two major groups of ways that can be done is by local deployment, so deploying models on your local infrastructure behind hospital firewalls, usually smaller open source models, because you need a lot of compute to run these things.
Mistral or something like that.
Exactly. And then the second group is on these cloud providers servers. So, Microsoft Azure, Google Cloud, they have the service where they will deploy and host these models in their massive data centers. And we can access those securely via our hospital tenant of those systems. So for instance, UHN has, Microsoft Azure and the hospital tenant where you can securely access these models within the realm of the hospital infrastructure and data transfer. And so we can securely access those models within the realm of UHN's data environment, essentially.
Okay.
And so we're able to securely access these tools and host applications in secure cloud. And that's how we're using them from a security aspect. The second thing you mentioned is kind of how do we use these creative LLMs for actual narrow clinical tasks? And that comes down to how we optimize the models. So these are very powerful tools. We can optimize them to perform repetitive tasks or various tasks, in various ways. Not to get into the weeds, but we mentioned long prompts, giving them context, prompt engineering, introducing data through something called retrieval augmented generation, or introducing knowledge through something called RAG, where it can pull chunks of information from high quality sources to augment that information, fine tuning to train on additional data to, have it, behave in a way that you want. And there are parameters that you can adjust as well to make it more reliable and repeatable. So, that's kind of what all of our research is trying to leverage these very flexible tools in ways to pretty quickly spin up applications that work for these applications that we're using them for.
Perfect. So you kind of get them to do what you want them to do.
Exactly.
Instead of just using the ChatGPT out of the box, you just use the network itself. But then what exactly are these agents? We keep hearing about agentic AI. What are these agents and what do these agents do for us? Are they going to help us like transcriptionists, like sit with us and help us get better, or how do they work in general?
Yeah, so I think the word agent or agentic AI it's been the buzzword for 2025 and now 2026 as well. And people use the term agent very loosely and slap it on their product. At RSNA, you see it at every booth: agentic AI, agents. Using agents to power healthcare.
Yeah, in my mind, it's like the secret agent 007. He's standing in a corner, protecting us and helping us somehow.
Yeah, exactly. And so the way that I personally think of agents, I think an AI agent is a system that uses AI to carry out a complex multi-step task in a way that it's autonomously, and the key word is autonomously, planning actions, steps, and then choosing how it's going to carry out those steps. So there's an actual element of autonomy to these AI agents when it's kind of carrying out these more complex tasks. And that is distinct from an agentic workflow. And Anthropic has the best definition, or has put out the best definition of agentic workflows that I've heard. Agentic workflows are multi-step processes or multi-step tasks using large language models or AI, but they're more constrained and kind of, along a multi-step, more predictable path. Step A to B to C, they're on the rails per se, or is one way to put it. And we've experimented with agentic workflows in radiology. So for things like, for instance, extracting coronary calcium that's incidental from reports, also extracting things like downstream of that, whether they're on a statin or various medications and other tasks in the chart, to then identify which are patients that can benefit from primary prevention. So I will say that agentic workflows, when they're very short in with respect to how many steps are involved, they can work very well if optimized to do so. But in my mind, when those workflows get very long, or you're trying to implement true agentic AI or true AI agents in or for radiology tasks, if you think about it, if they're carrying out multiple steps and there's an error rate at each step, that error rate is going to compound, right? An error early on is going to propagate through, and it compounds, and you can end up with widely off responses at the end of, your workflow or agentic workflow. So I think that compounding error is a problem that, in a field like radiology where we need reliability. For the foreseeable future, I think we're going to see more smaller agentic workflows that are more reliable, and agents can get a little haywire. And so I think that's, going to be something that's going to mature over the next few years, but it's something that, still leaves some space to be or some work to be done.
Is that what we keep calling hallucination? And has that improved over time because ChatGPT is now 3-year-old? Like, do you think
that? For sure. The hallucination rate has obviously decreased as models get better, and there are tools or tool use to things like I mentioned, like pulling in high quality data, for instance, from high quality sources. There are many different things that can be done to ground the information or ground the responses in high quality information, I should say. So there are ways to reduce hallucinations in an individual step. But with these, agentic workflows and agents, in a setting like healthcare, where sometimes the information in the chart is incomplete or sometimes contradictory even, that can be propagated through, and that's where we have to be careful. And I think where, the bottleneck is right now for, true agents in radiology.
And even a small error rate is not tolerated. Similar to self-driving, right? You can't tolerate small errors, I guess.
Exactly, yeah.
But as you point out, like, things have significantly improved over time, and you are using AI applications, at least in narrow focus, to improve certain administrative tasks, not only to decrease burden, but also to improve homogeneity and better patient care, getting better histories, better protocoling, and better reporting.
And just to say, those are all supervised applications. So obviously the radiologist is still verifying the protocols on them. They're verifying the reports, but it's augmenting or helping how they do things.
Absolutely. But what is the cost of not doing so? Given the fact that AI has rapidly improving over time, and we can just predict that it's still going to have lesser errors, it's going to be better over time, agentic AIs are going to be better. What are the primary bottlenecks which an organization like UHN or any big organization faces currently? And how do you kind of overcome that, and what are the costs of choosing not to do so now?
Yeah, so I would say that, the bottleneck is not innovation, right? There's innovation, and you can make performant models, and people have been doing these in different, avenues for a long time. The bottleneck is the integration piece, right? We have these complex systems that are all stitched together, and anytime there's innovation or change and you want to bring it to practice, it's not about that individual tool. It's how do I actually bring that into practice in a safe way that's integrated appropriately, securely, works well with the systems, doesn't introduce errors or a break in the system as a result of that integration. And so I think it's the integration piece that is often the bottleneck. And to go back to what we were talking about earlier at the beginning of the podcast, having systems that are somewhat unified, or at least have been integrated again and again, and have a track record of strong, tight integration, enables us to be able to have some modularity with narrow use cases, as we push things forward. So it gives you that, paradoxically, it gives you that flexibility as well. So I think that's probably the biggest bottleneck, and we have to modernize our infrastructure so that they can play nice with one another. If you're on old technology and you're trying to integrate new technology, you're integrating backwards compatible, and it can be a mess. It's integrating from scratch every time. It can be a mess, and that kind of holds back our ability to open the floodgates, if you will, for actually bringing innovation to practice and actually improving on some of these things that we know are suboptimal in care today.
Oh, absolutely. Okay. So I think what you're trying to say is that every system which currently is separate in radiology has to all be improved kind of at the same time. Because if you have innovation in one and then it doesn't integrate with another system, then it's not really going to work. It's like trying to play Crisis on Windows 95 or something like that. Like, you need to have the best of both.
To a degree,
Or-
and especially the core enterprise solutions. Right? They need to be modernized to be able to facilitate
The other
that
modular
work,
things
yeah.
which are kind of plugging into it.
Exactly.
And down the line, what do you expect to see? We always like repeating this quote of Jeff Hinton, who said that stop training radiologists because in 5 years, we won't need them. It's been 10, 11 years since that quote was said. We're still here, and we're still working hard with extra cases and backlog and a huge number of cases to be read. But at least in terms of the technology side of things, where do you think things are going to progress given the rate of change you've seen in the last 3 years? The next 10 years, are things going to be better for us, or are we going to be still struggling with the same problems, or will we have a new set of problems to struggle with?
My personal opinion is that in the next 5 to 10 years, a lot more is going to stay the same than is going to change, right? There are going to be a lot of things that are improved,
Okay.
right? There are going to be narrow areas that we know are problems now that are going to be augmented. So I think, it's going to be important in the future that our workflow is more optimized. There are a lot of suboptimal things that we talked about today that can be improved upon, and I think will be more maturely improved upon by then. I think that, demand for radiology is going to continue to increase, maybe even faster. I don't think we'll be out of a job. But again, I think augmentation of workflow, as well as on the imaging side, things like picking up incidental findings, missed pancreatic cancers have an immense impact to our health system. So, things like that kind of can pick up on incidental findings that are commonly missed or act as another set of eyes for radiologists to augment what we do. Okay. And then eventually, we're seeing some flashes of this in some narrow areas, preliminary reports for radiologists as well to kind of, it's almost like having a resident or a fellow kind of write a report for you, and then you can edit it downstream of that. That I think is going to be a reality for several modalities in the next 5 to 10 years to make us more efficient. But at the end of the day, the AI is going to be good at certain things, and we're going to be good at certain things. And, we're not going to be out of a job as a result of that for sure. I will say, though, I think that what we choose to implement AI on and the workflows and parts of the image that we choose to implement at scale is super important and has to be done carefully.
Okay.
If you think about it, AI, like any other tool, AI is a tool, and it amplifies our efforts. And if we amplify our efforts that end up not having any actual patient benefit, what are we doing?
Yeah.
And so you need prospective, randomized control trials that demonstrate an actual improvement to patient endpoints before we're implementing this at scale, right? If you decide to pick up on some incidental finding, again and again at scale across, let's say all of Canada, and then you're bringing in these patients, you're now turning people into patients, you're medicalizing more people.
Yeah.
You're picking up on incidentals that may not have done anything. In that process of medicalization, we know that there are potential harms downstream of that. And that's why you need high quality research and randomized control trials that prove that an intervention actually improves patient outcomes and patient lives. And if we just amplify everything with AI, we're going to amplify both things, the things that benefit patients as well as the things that don't. Okay. And so, for prospective, smaller scale analyses, you can explore AI tools in these areas. Is it picking up more cancers? Is it, what is it doing? But before implementation on a very wide scale, you need that. Otherwise, things can go off the rails quickly, and we can feel good about ourselves. Oh, we're picking up more of this, or we're picking up more of that. But are we actually helping patients? And that's really the goal at the end of the day, and should be the end goal of a lot of what we're doing with AI. So,
absolutely. Ultimately, we want the best for our patients, and we need to make use of all technology to get the best patient care. And so we always think about it like, oh, we're going to be out of a job because if AI can read images better. But one thing we keep forgetting, as you point out, is that the imaging technology is also improving. We have newer CTs now. We have dual energy CT. We have now subtraction CT, photon counting CT is just on the horizon in UHN. In other places, it's implemented already. MRI, we have new sequences as well. And each time we have a breakthrough in terms of imaging technology, we need like a whole new process of validating it, testing it, and making sure it actually works okay. So I think that we still are needed to make sure that all these technologies are used in the best way possible. But I think I'll probably end saying that most radiologists, we're all concerned about looking at images, the best imaging technology, the best identification of abnormalities in images, best image quality. But I think that the technology behind it is also very important, and not just behind the imaging itself, but also behind all the other workflows that we do. Because only if all of these are optimized, like let's say if they have the best CT scanner ever, but if all these processes by which we produce a report are broken, we still will not be able to give the best patient care ever. So technology, both on the imaging side as well as on the administrative side, are incredibly crucial. And again, we're only as good as the weakest link. So we need more radiologists to kind of take the lead in other institutions, to kind of push for improvements in these areas so that we can deliver our care better for the patients. Because at the end of the day, all we want is the best patient care.